Hormones are the substances secreted by highly specialized cell and carried by the extracellular fluid and access target organs where they alters the activity of the cells quantitatively, which influences metabolism, growth, reproduction, adaptation to the environment. Hormones carry messages from the gland to cell to maintain the chemical level in the bloodstream that achieves hemostasis. Gland manufacture hormones. Hormones circulates freely in the bloodstream, waiting to recognize by the target cell their intended destination. The target cell has a receptor that can only be activated by specific type of hormones. Once activated, the cell knows to start certain functions within the cell walls. There are two types of hormones, the steroid and peptides. In general, the steroid or sex hormones related to sexual maturation and fertility. The steroids are made from cholesterol. The cortisol is an example of steroid hormones. The peptide regulates other functions such as sleep and sugar level. They are made from long strings of amino acids, so sometimes they are referred to as a protein hormones. The growth hormones helps us to burn fat and build up muscles. Insulin starts the process converting the sugar into cellular energy. As a special category, the autocrine hormones acts on the cell by secreting glands, while parasin hormones or acts on nearby but under the cells. Chemical classes of hormones. The vertebrate hormones falls into three categories. Amine derivative hormones are derived of amino acids tyrosine and tryptophan. Examples are catecholamine and thyroxine. Peptide hormones consist of a chain of amino acids. Examples of small peptide hormones are vasopressin T or H. The peptide composed of scores of hundreds of amino acids and are referred to as a protein. Examples of protein hormones include insulin and growth hormones. More complex protein hormones bears carbohydrate side chains and are called glycoprotein hormones. Luteinizing hormones, follicle stimulating hormones, and thyroid stimulating hormones, or glycoprotein hormones. Lipid and phospholipid derived hormones derived from the lipids are called as enolic acid and arachidonic and acid and phospholipids. The main classes are the steroid hormones that derive from the cholesterol and eicosanoids. Examples of steroid hormones are testosterone and cortisols. The steroid hormones such as calcitriol or homologous system. The adrenal cortex and gonads are the primary source of steroid hormones. Examples of eicosanoids are widely studied prostaglandins. General endocrinology. In classical endocrinology, hormones are grouped into pituitary hormones, thyroid hormones, parathyroid, pancreatic, suprarenal cortical hormones, suprarenal medullary hormones, ovary hormones, testicular hormones, hypophyseal hormones. Mechanism hormone action. The hormone binds to the site on the extracellular portion of the receptor. The receptor or transmembrane proteins that passes through the plasma membrane 7 times with their N-terminal exposed at the exterior of the cell and the C-terminal projecting into the cytoplasm. Binding of the hormone to the receptor activates the G protein. This initiates the production of second message like cyclic AMP, which is produced by adenyl cyclase from ATP inositol 1,4,5 triphosphate. The second message is in turn initiates the series of intracellular events such as phosphorylation and activation of enzymes releases Ca2 plus into the cytosol from stores within the endoplasmic reticulum. In the case of CAMP, these enzymatic changes activates the transcription factor CREB, bound to its receptor element in the promoter of the gene that are able to respond to the hormone. Activates CREB, turns on gene transcription, then to translate to produce desired proteins. The biochemical response is achieved finally. The cell being to produce the appropriate gene produces in response to the hormonal signal it had received at its surface. Pituitary hormone. The endocrine is a gland which serves as a hormone and also diuretic gland. As a hormone is carried not by the duct but by the blood. Pituitary gland comprises of anterior pituitary lobe, posterior pituitary lobe, and intermediate lobe. Anterior pituitary lobe. Growth hormone, thyroid stimulating hormone, follicle stimulating hormone, luteinizing hormone, adrenocorticotropic hormones, prolactin, alpha melanocyte stimulating hormones, growth hormones. The human growth hormones, also called as somatotropins, is a protein of 191 amino acids. The growth hormone secretions are stimulated to synthesize and release growth hormones by intermittent arrival of growth hormone releasing hormones from the hypothalamus. Direct effects or result of growth hormones binding its receptor on foreign cells. The fat cells, for example, have growth hormone suppressor, and growth hormone stimulates them to break down triglycerides and suppresses their ability to take up the accumulation of circulating lipids. Indirect effects or primarily by insulin growth hormones, a hormone that is secreted from the liver and other tissue is responsible to the growth of hormones. A majority of the growth promoting effect of growth hormone actually does due to the IGF-1 acting on the target cells. Pathophysiology. In childhood, the hyposecretion of a growth hormone produces a stunted growth of dwarfism can also result in the inability to respond to growth hormone. This can result from the inheriting two mutant gene encoding the receptors. The growth hormone deficient symptoms. The symptoms of growth hormone deficiency in children includes the following: short stature, low growth velocity for age and puberty stage, increased amount of fat around the waist, child may looks younger than other children his or her age, delayed tooth development, delayed onset puberty. Symptoms of growth hormone deficiency in adult includes low energy, decreased strength and exercise tolerance, decreased muscle mass, weight gain especially around the waist, feeling of anxiety, depression or sadness causes a change of social behavior. The effect of excessive secretion of growth hormone is also very dependent on the age onset as soon as to distinct order. Hypersensitivity leads to the gigantism of children. Gigantism is the result of excessive growth hormone secretion that begins in young children or adults, and it is a very rare disorder, usually resulting from a tumor of somatotropes. In adults, the hyper secretion of the growth hormone leads to acromegaly. Acromegaly results from the excessive secretion of growth hormones in adults, usually the results of a benign pituitary tumor. The onset of this disorder is typically insidious, occurring over several years. The clinical signs of acromegaly includes overgrowth of extremities, soft tissue swelling, abnormalities in the jaw structure, and cardiac disease. The excessive growth hormones and IGF-1 also leads to the number of metabolic derangements, including hyperglycemia, thyroid sensitizing hormone TSH. The TSH is a glycoprotein consisting of a beta chain 112 amino acids and an alpha chain of 89 amino acids. The alpha chain is identical to that found in the two other pituitary glands, the FSH and luteinizing hormones. Thus, its best chain that gives thyroid stimulating is unique property. The secretion of TSH is stimulated by the arrival of thyrotropin releasing hormones from the hypothalamus, inhibiting the arrival of somatostatin from the hypothalamus. As its name suggests, TSH stimulates the thyroid glands to secrete the hormone thyroxine T4. Normal value is 0.3 to 5 milli international unit. ಇಲ್ಲ ಮೊದಲ follicle stimulating hormone. In female, it acts on ovary to stimulate the development of ovarian follicles. In male, FSH acts on the testes for maturation of sperm. It is a glycoprotein hormones like LH, luteinizing hormone, HCG, and testicular stimulating hormones. Thyroid stimulating hormones consist of two non-covalently associated subunits, alpha and beta. The beta subunit confirms its immunological and functional specificity. The gonadotropic cell of anterior pituitary secretes both FSH and luteinizing hormones in response to the gonadotropin releasing hormones. It controls growth and reproductive activity of gonadal tissue. Follicular cycles 33 to 20 molar milli international unit per ml, mid cycle 9 to 26 m international unit per ml, luteal cycle 1 to 12 m international unit per ml, menopausal 18 to 153 m international unit per ml, in males 1 to 12 m international unit per. Luteinizing hormones in female, it stimulates the ovarian follicles to mature and also to secrete estrogen. Therefore the estrogen modulate the secretion of luteinizing hormone FSH, which in terms regulates the menstruation cycle in female. In male, it stimulates the secretion of testosterone. The determination of concentration of luteinizing hormone is essential for the prediction of ovulation, in evaluation of infertility, and diagnosis of pituitary and gonadal disorder. Normal in female, follicular cycle 2 to 15 m international unit per ml, mid cycle 12 to 105 m international unit per ml, luteal cycle 0.6 to 19 m international unit per ml, menopausal 16 to 64 m international unit per ml, in males 2 to 12.5 m international unit per ml. Adrenocorticotropic hormones, it stimulates the adrenal glands to secrete adrenal cortical and medullary hormones. The adrenocorticotropic hormones is a peptide of 39 amino acids. It is cut from larger precursor, opinomelanocortin (POMC). The ACTH acts on the cell of adrenal cortex, stimulating them to produce their hormones. Pathophysiology: if adrenocorticotropic hormones secretion is increased by pituitary or by ectopic production from the tumor, it results in Cushing syndrome. The decrease of adrenocorticotropic hormone production leads to Addison's disease. Prolactin. The prolactin is a protein of 198 amino acids. During pregnancy, it helps in preparation of breast from future milk productions. After birth, the prolactin promotes the synthesis of milk. The prolactin secretion is stimulated by TRH and repressed by the estrogen and dopamine. Pathophysiology: the hyperprolactemia is caused by the infertility in female. The secretion of prolactin is stimulated by TRH and inhibited by PEIF. Normal female 5.4 to 22.5 nanogram per ml. Mid-cycle 4.5 to 15 nanogram per ml. Menopausal women, female, and women 4.2 to 15 nanogram per ml. Posterior pituitary hormone, vasopressin. It is originally named because of its ability to control blood pressure when administered in pharmacological amount, but more appropriately it is called as a antidiuretic hormones, because of its important function to promote reabsorption of water from distal convoluted tubes. If there is a defect in antidiuretic hormone secretion or decreased action, it may lead to diabetes insipidus. Diabetes insipidus is characterized by the excretion of a large volume of dilute urine. The primary diabetes insipidus and insufficient secretion of hormone, which is due to destruction of the hypothalamic hypophyseal tract, arises due to the basal skull fractures, tumor, or infection. It may be hereditary also. Biochemical findings: decrease specific gravity, decrease ADH, dilute urine, and polyuria. Oxytocin production, it is produced in hypothalamus and transported to posterior pituitary gland. Appropriate stimulation releases the hormone into the blood. The neural impulses that results from the stimulation of nipple or primary stimulus in oxytocin release. Vaginal and uterine distension is the secondary stimuli. Estrogen also stimulates the production of oxytocin. Oxytocin causes a contraction of uterine smooth muscles, and thus it is used in pharmacological amount to induce labor in human. The most likely physiological function of oxytocin is stimulation from the contraction of cells surrounding the mammalian alveoli. This promotes the movement of milk into the system and allows milk ejection. Thyroid gland synthesis and secretes T4 and T3. Thyroid gland releases its hormone up to stimulation by TSH. The thyroxine T4 is derivatives of amino acid tyrosine with 4 atoms of iodine. In the liver, 1 atom of iodine is removed from T4, converting it into the triiodothyronine. thyroid. The T3 is active hormone. It has many effects on the body. Among the most prominent of these are an increase in metabolic rate, an increase in rate and strength of the heartbeat. The thyroid cells are responsible for the synthesis of T4, makes circulating iodine from the blood. The thyroid hormone stimulates gluconeogenesis, RNA synthesis, protein synthesis. Increased T3 concentration causes protein catabolism and negative nitrogen metabolism. This is one of the reasons for weight loss in hyperthyroidism. Synthesis of T3 and T4. Tyrosine plus iodine gives monoiodo tyrosine. Monoiodotyrosine plus monoiodotyrosine gives a diiodotyrosine. Monoiodotyrosine plus triiodotyrosine. Diiodotyrosine plus diiodotyrosine tetraiodotyrosine. Hypothalamic pituitary thyroid negative positive feedback system. Pathophysiology hypothyroidism. The hypothyroidism disease caused by the inadequate production of T3. Over 90% of the cases of hypothyroidism occurs because of autoimmune destruction of a thyroid gland, radioiodine or surgical treatment of hypothyroidism. Creatinism. The hypothyroidism in infancy and childhood leads to the stunted growth and intelligence. It can be corrected by giving thyroxine if started early enough. Myxedema. The hypothyroidism in adults leads to lowered metabolic rate and vigor. It can be reversed by giving the thyroxine. Goiter, enlargement of thyroid gland, inadequate iodine in diet with resulting low level of T4 and T3. An autoimmune attack against the components of thyroid gland called Hashimoto thyroidism. This the region of hypothyroidism disease produces an enlarged gland. Activity of thyroid is under negative and feedback control. The synthesis and release of TRH and thyroid stimulating hormone is normally inhibited as the level of T4 and T3 rise in the blood. When iodine supply in is inadequate, T4 and T3 level falls. This stimulates the hypothalamus and pituitary to increase the TRH and TSH activity respectively. This stimulates the thyroid gland to enlarge. Symptoms: grave hyperthyroidism. It is caused by the generalized over activity of the thyroid gland. In this condition, thyroid gland usually loses capacity responding to normal control of the pituitary gland via TSH. The Graves' disease is hereditary and is more common in women than men. The trigger of Graves' disease includes stress, smoking, radiations of neck, medications, infectious organs. The disease can be diagnosed by the nuclear medicine, thyroid scan, and blood test. This disease may be associated with eye diseases, osteoporosis. High level of thyroid hormones suppresses the production of TSH through the negative feedback mechanism mentioned above. The resulting low level of TSH causes an increase in number of bone reabsorption, osteoclast, resulting in osteoporosis. Diagnosis: measuring the level of thyroid stimulating hormone produced by the pituitary gland in a pituitary gland in the blood is typically the initial test for suspected hyperthyroidism. A low level thyroid stimulating hormone level typically indicates the pituitary is being inhibited by instructed by the brain to cut back to on stimulation of thyroid gland. Having sensed increased level of T4 and or T3 in the blood in rare circumstances, the low TSH indicates primary failure of pituitary or temporary inhibition of pituitary due to the another illness. And so checking the T4 and T3 is still clinically useful. Measuring specific antibodies such as anti-TSH receptor antibody in Graves' disease or anti-thyroid peroxidase in Hashimoto's thyroid disease, a common cause of hyperthyroidism, may also contribute to the diagnosis. Biochemical findings: increased T3, T4 and TSH decrease in normal value. T3 0.822 microgram per ml, T4 4.5 to 12 microgram per ml. Parathyroid hormone. parathyroid hormones function the calcium homeostasis. The parathyroid hormone restores normal calcium concentration by acting directly on the bone and kidney and acting indirectly or on intestinal mucosa bone. It increases the reabsorption in both organic and inorganic phases, which loses calcium 2% and ECF kidney. It reduces the renal clearance and excretion of calcium and hence increases the ECF concentration of calcium. The GID. It increases the efficiency of calcium absorption from the intestine by promoting the synthesis of calcitonin. It acts upon the intestine by increasing the Ca2 plus absorption and plays a presumptive role of PTH on bone and kidney. The parathyroid hormone increases the renal phosphatase clearance, and thus the net effect of parathyroid hormone on bone and kidney is to increase ECF and Ca2 plus concentration, decreases ECF PO4 concentration. Excessive secretion of parathyroid hormones is seen in two forms. Primary hyperparathyroidism. It is the disorder of a parathyroid gland. The most people with this disorder have one or more enlarged overreactive parathyroid gland that secretes too much parathyroid hormones. The secondary parathyroid problems such as kidney failure makes the body resistant to the action of parathyroid hormone. This excess parathyroid hormone triggers the release of too much calcium into the bloodstream. The bone may lose calcium and too much calcium may be absorbed from the food. The level of calcium may increase in the urine, causing kidney stones. The parathyroid hormones can also act to lower blood phosphorus level by increasing the excretion of phosphorus in the urine. Inadequate production of parathyroid hormone hypoparathyroidism results in decreased concentration of calcium and increased concentration of phosphorus in the blood. The common cause of this disorder includes the surgical removal of a parathyroid hormone and disease processes that leads to the destruction of a parathyroid gland. The resulting hypocalcemia often leads to tetany and convulsions and can be even actually life-threatening. Adrenal gland. The adrenal gland comprises of cortex and medulla. Cortex has again three zones. A zone of glomerulus produces mineral corticoids. Zone of fasciculate produces glucocorticoids. Zone of reticularis secretes sex steroids like androgens and estrogen. Corticosteroids. It is a steroid hormone. It is mainly derived from cholesterol. The function of a glucocorticoid in the humans or glucocorticoids gets their name from their effect of raising the level of blood sugar. They do this is by stimulating the gluconeogenesis in the liver, the conversion of fats and protein into the intermediate metabolites that are ultimately converted into glucose. The most abundant glucocorticoid is cortisol. Cortisol and other glucocorticoids also have protein and anti-inflammatory effect on the body. They possess the immune responses, especially cell-mediated immune responses. They are widely used in the therapy to reduce inflammatory restrictions of rheumatoid arthritis and other autoimmune diseases, to prevent rejection of transplant organs, to control asthma. The assessment of glucocorticoid secretion. The plasma of serum cortisol level determined is one of the methods for assessing the secretion of glucocorticoid. The cortisol level is determined by the radioimmunoassay enzyme linked immunosorbitase and fluoroimmunoassay. Normal 8 to 26 microgram per deciliter at AM and 8 to 18 microgram per deciliter at ppm. Control of the estimation of urine-free cortisol and 17 ketostol are helpful in assessing our glucocorticoid secretions. Urine cortisol normal up to 150 microgram per 24 hours. Urine steroids male 8 to 20 milligram per 24 hours. Female 6 to 15 milligram per 24 hours. Control of cortisol secretion. Cortisol and another glucocorticoid are secreted in response to single stimulator adrenocorticotropic hormones from the antirespiratory. The adrenocorticotropic hormones is itself secreted under control of hypothalamic peptide corticotropic releasing hormones CRH. The central nervous system is thus the commander and the chief glucocorticoid response, providing excellent example of close integrated between the nervous and endocrine system. They virtually any type of physical and mental stress results in elevation of cortisol concentration in blood due to the enhanced secretion of corticotropic releasing hormones in the hypothalamus. This fact sometimes makes it very difficult to assess the glucocorticoid level, particularly in animals. Observing the approach of phlebotomist and especially being restained for blood sampling, it is enough stress to artificially elevate the cortisol levels several fold. The cortisol secretion is suppressed by classical negative feedback loops. When blood concentration rises above a certain threshold, the cortisol inhibits CRH secretion from the hypothalamus, which turns off adrenocorticotropic hormones secretion, which leads to the turn of cortisol secretion from the adrenal. The combination of positive and negative controls of the corticotropic releasing hormones secretion results in the pulsatile secretion of cortisol. Typically, the pulse amplitude and frequency are the highest in the morning and the lowest at night. The adrenocorticotropic hormones binds to the receptor in the plasma membrane of the cell in a zona fasciculata and reticularis of adrenal. Hormone receptor engagement activates the adenyl cyclase, leading to elevated intracellular level of cyclic AMP, which leads ultimately to activation of enzyme system involved in the biosynthesis of cortisol from cholesterol. Mode of action: the cortisol binds to the cytolytic glucocorticoid receptor. This type of receptor is activated by ligand binding. After hormone is bind to the corresponding receptor, the newly formed receptor by ligand complex translocate itself into the cellular nucleus, where it binds to many glucocorticoid response element in the promoter region of a target gene. The opposite mechanism is called trans repression. The activated hormone receptor interacts with specific transcription factor and prevents the transcription of target genes. Addison's disease is a rare endocrine or hormonal disorder that occurs in all age groups. In this condition, the adrenal gland reduces a insufficient amount of steroid hormones. The disease is called as adrenal insufficiency or hypocortisolism. Causes the failure to produce adequate level of cortisol and can occur in different reasons. The problem may be due to the disorder of adrenal glands themselves, primary and adrenal insufficiency, and in the inadequate secretion of adrenocorticotropic hormones by pituitary gland. This form of adrenal insufficiency is much more common than primary adrenal insufficiency and can be traced to a lack of adrenocorticotropic hormones. Without adrenocorticotropic hormones to stimulate the adrenal gland, production of cortisol drops, but not aldosterone. The temporary form of secondary adrenal insufficiency may occur when a person who has been receiving a glucocorticoid hormones such as prednisone for a long time abruptly stops or interrupts lacking medication. The glucocorticoid hormones, which are often used to treat inflammatory illness like rheumatoid arthritis, asthma, and ulcerative colitis, block the release of both corticotropins releasing hormones and adrenocorticotropic hormones. Normally, the CRH corticotropic releasing hormone instructs the pituitary gland to release adrenocorticotropic hormones. If the corticotropic releasing hormones level drops, the pituitary is not stimulated to release adrenocorticotropic hormones, and adrenal then fails to secrete a sufficient level of cortisol. Another cause of secondary adrenal insufficiency is surgical removal of a benign or non-cancerous adrenocorticotropic hormone producing tumor in pituitary gland. Other causes can less common or causes of pituitary adrenal insufficiency or cancer cells spread from other parts of the body to adrenal gland. The essential role of adrenal corticotropic hormones means the deficiency can be life-threatening. Fortunately, replacing therapy with a glucocorticoid and mineralocorticoid can permit the normal life. Diagnosis of Addison disease is made by laboratory tests. The aim of this test is first to determine whether the level of the cortisol are insufficient and then to establish the cause. ACTH adrenocorticotropic stimulating test. This is the most important specific test for diagnosis of Addison disease. This is blood cortisol, urine cortisol, or both are measured before and after synthetic form of adrenocorticotropic hormones is given by injection. In the so-called short or rapid adrenocorticotropic hormone test, measurement of cortisol in blood is repeated 30 to 60 minutes after an interval of adrenocorticotropic injection. The normal response after an injection of adrenocorticotropic hormones is a rise in blood and urine cortisol levels. The patient with either form of adrenal insufficiency response poor or do not respond to all routine investigation may show hypoglycemia, hyponatremia, hypokalemia, eosinophilia, and lymphocytosis. Cushing syndrome. The Cushing syndrome is a hormonal disorder caused by the prolonged exposure of body tissue to high level of hormonal cortisol. In Cushing syndrome, the level of adrenal hormones, especially of glucocorticoid, is too high, causes excessive production of adrenocorticotropic hormones by anterior lobe of pituitary, excessive production of adrenaline hormone themselves, ectopic adrenocorticotropic hormone. Some benign or malignant tumor that arises outside the pituitary can produce the adrenocorticotropic hormone. This condition is known as ectopic adrenocorticotropic hormones. Lung tumor causes over 50% of this disease as a result of glucocorticoid therapy. For some other disorders such as rheumatoid arthritis or decreased glucocorticoid hormone synthesis symptoms: hypoglycemia, high blood pressure, severe protein catabolism resulting in thickening of skin, muscle wasting, osteoporosis, and negative nitrogen balance. There is a peculiar redistribution of the fat in the trunks, moon phase. 24 hours urine free cortisol level. This is the most specific diagnostic test. The patient urine is collected over a 24 hours period and tested for cortisol. If the cortisol level is higher than 50 to 100 micrograms a day for an adult, suggests Cushing's syndrome. The normal range may vary from laboratory to laboratory depending on the technical use. Dexamethasone suppression test. This test is used for distinguishing patient with the excess production of adrenocorticotropic hormones due to the pituitary adenomas from those with ectopic adrenocorticotropic producing tumors. Patients are given dexamethasone, a synthetic glucocorticoid, by mouth every 6 hours for 4 days. For the first 2 days, low dose of dexamethasone are given, and for the last 2 days, higher dose are given. 24 hours urine samples collected and are made before dexamethasone is administered on each day for the test. Since cortisol and other glucocorticoid signal the pituitary to lower secretion of adrenocorticotropic hormone, the normal response after taking dexamethasone is a drop in blood and urine cortisol levels. Different responses of cortisol to dexamethasone are obtained depending on whether the cause of Cushing syndrome is pituitary edema or an ectopic. CRH dexamethasone suppression test can produce a false positive result in patients with depression, alcohol abuse, high estrogen level, acute illness, stress. Conversely, drugs such as phenytoin and phenobarbital may give us false negative results in response to the dexamethasone suppression. For this reason, patients are usually advised by their physician to stop taking these drugs at least 1 week before test. CRH simulation. This test helps in distinguishing between the patient with the pituitary adenomonas and those with ectopic adrenocorticotropic hormone syndrome or cortisol secreting adrenal tumors. The patients are given an injection of a CRH, corticotropic releasing hormones. The corticotropins releasing hormones that causes the pituitary to secrete adrenocorticotropic hormone. The patients with pituitary adenomonas usually experience a rise in blood level of adrenocorticotropin and cortisol. This response is rarely seen in patients with ectopic adrenocorticotropic hormone syndrome and practically never in patients with cortisol secreting adrenal tumors. Mineralocorticoids. It is steroid hormones mainly derived from the cholesterol. The mineralocorticoids gets the name from their their effect on mineral metabolism. The most important of them are steroid aldosterone. Aldosterone acts on kidney, promoting the reabsorption of sodium ions into the blood. Water follows the salt, and this helps maintain the normal blood pressure. The adrenosterone also acts on sweat glands to reduce the low of sodium and perspiration. It act on taste cells, increases sensitivity of taste buds to source of sodium. This is secretion of aldosterone is stimulated by a drop level of sodium ion in the blood, a rise in level of potassium ion in the blood, angiotensin 2, and adenocorticotropic hormones. Primary aldosterone or COS syndrome. Adrenal medulla secretes dopamine, adrenaline, noradrenaline. The functions the adrenal medulla consists of masses of neurons that are part of sympathetic branches of automatic nervous system. Instead of releasing the neurotransmitters at synapses, these neurons releases them into the blood. Thus, although part of nervous system, the adrenal medulla functions as an endocrine gland. The adrenal medulla releases adrenaline and noradrenaline. Both are derived from the amino acid thyrosin. The release of adrenaline and noradrenaline is triggered by nervous stimulation in the response to the physical and mental stress. Importance of catecholamine and principles of increase some of the effects are increase in the rate of strength of heartbeat, resulting in increase in blood pressure, blood started from the skin and viscera of the skeletal muscles, coronary arteries and liver membrane. Rise in blood pressure, sugar increases in metabolic rate, bronchi dilated, pupil dilated, hair stands on end, reduce quality time, increases ACT secretion from the anterior lobe of pituitary, promotes glycogenolysis, increases glycogenolysis, stimulates lipolysis, helps to uptake the amino acids. Importance of catecholamine and its principal metabolite estimations. The catecholamine are derived from the thyrosin. They are named so because the presence of catecholamine the major catecholamine or epinephrine, norepinephrine and dopamine produced by the adrenal medulla. The increased catecholamine production may be result in the permanent hypertension. The pheochromocytoma, the excessive productions of catecholamine. The catecholamine assays are helpful in the direction of cases of pheochromocytoma. The pheochromocytoma is relatively rare and usually being tumor arises from the chromaffin cells. This results in the hypersecretion of catecholamine. It is important to diagnose it because it is surgical curable, and even more significantly it can cause death from acute hypertensive attack. The excessive production of catecholamine and their principal metabolites results in the hypertension. Epinephrine is stored in chromaffin granula and catabolizes to vinyl maladic acid. The VMA excreted in the urine in an induction of the production of catecholamine. VMA can be estimated in the 24 hours urine sample colorimetrically. Sample 24 hours urine. Normal value of excretion of vinyl malonic acid is 2 to 6 milligram per 24 hours. It is increased in pheochromocytoma. Generally, the total urine methanephrin test on 24 hours sample is preferred test screen test. Pancreas alpha cells of pancreas secretes glucagon and beta cells of islet of ganges of pancreas secreting insulin. Insulin is a polypeptide hormone secreted synthesized from the beta cells of islet of ganges of pancreas. It is synthesized as a larger precursor called as a pre-pro-insulin. The pre-pro-insulin has 109 amino acids. It is immediately converted into pro-insulin in endoplasmic reticulum by the removal of 23 amino acids. So the pro-insulin formed contains 86 amino acids. The pro insulin is transported to the Golgi apparatus and it's cleaved to form to from insulin and C peptide. The C peptide contains 33 amino acids. Insulin formed from the pro-insulin contains 53 amino acids, from which 2 amino acids are cleaved to form insulin and 51 amino acids. With 51 amino acids, insulin mainly controls blood glucose by controlling mechanism structure of human insulin. Human insulin contains 51 amino acids are arranged to polypeptide chains, namely alpha chain and beta chain. The alpha chain consists of 21 amino acids and the beta chain consists of 30 amino acids. The alpha chain and beta chains are held together by the pair of interchain disulfide bond and an interchain disulfide bond. One interchain disulfide bond is between 7th cysteine and alpha chain is 7th cysteine. A chain. Another disulfide bond is between the 20th cysteine of alpha chain and the 19th cysteine of alpha chain. The intra chain disulfide bond is between 6th and 11th cysteine residue of alpha chain. The insulin formed is packed into the granules in a Golgi apparatus with 2 zinc ion and 1 calcium ion. By exocytosis, these insulin granules are released into the circulation along the C peptide. Both C peptide and insulin are produced in equimolar concentration. The C peptide has no biological activity. The insulin mainly controls the blood glucose by the following mechanisms: increase the uptake of glucose by peripheral cells, increases the utilization of glucose by stimulation of glucose, stimulates glycogenesis and inhibits glycogenolysis, inhibits lipolysis, inhibits gluconeogenesis. Degradation of insulin. Insulin is rapidly degraded in the liver. The half-life of insulin in the plasma is 4 to 5 minutes. Insulin is mainly cleaved by insulinase and hepatic glutathione insulin trans dehydrogenase. Physiological actions of insulin. Insulin plays a major role in regulation of carbohydrate lipids protein metabolism. Effect of carbohydrate metabolism. Insulin increases the uptake of glucose by tissue. Insulin is necessary for the uptake of glucose like skeletal, cardiac, smooth muscles, adipose tissue, leukocytes, mammary glands. Insulin is not required for the uptake of glucose by brain, liver, kidney, erythrocyte, blood vessels, nerves, intestine, mucosa, and retina. About 80% of the glucose uptake in the body is not dependent on insulin. The remaining 20% of the glucose uptake is promoted by the insulin. Utilization of glucose. Insulin increases the utilization as stored of glucose. About 50% of glucose is ingested is ultimately utilized to meet the energy needed for the blood through the glycosis. About 40% of glucose converted into fat. The remaining 40%, 10%, the remaining 10% is converted into glycogen. Insulin stimulates the glycolysis and glycogenesis and inhibits the glyconeogenesis and glycogenolysis. Effect on lipid metabolism. Lipogenesis. The adipose tissue is the most sensitive to the action of insulin. Insulin enhances the synthesis of triacetyl glycosyrol from the glucose by providing more acetyl-CoA and NADPH. The insulin increases the activity of acetyl-CoA carboxylase, that is key enzyme in fatty acid synthesis. The insulin provides the NADPH requiring for fatty acid synthesis by increasing the activity of glucose 6-phosphate and dehydrogenase. Anti-lipolysis. In adipose tissue, the insulin inhibits lipolysis. This is by inhibiting the activity of hormone sensitive lipases. So mobilization of fatty acids from the adipose tissue and liver or decrease. Effect of ketogenesis. Insulin decreases the ketosis by formation of ketogenesis by decreasing the activity of HMG CoA synthetases. The insulin also favors the utilization of acetyl-CoA for oxidation of Krebs cycle and lipogenesis. So acetyl-CoA is not available for ketogenesis. Effect of protein metabolism. Insulin increases protein synthesis by increasing the uptake of amino acids into the cell. So insulin is an anabolic hormone. Insulin promotes cell growth and replication. Thus insulin is an essential growth factor for all mammalian cells. Regulation of insulin secretion. The main regulator of insulin is glucose. There are some stimulators of insulin secretion and some inhibitor of insulin resistance. Stimulation of insulin secretion. The insulin secretion is stimulated by glucose, amino acids, pancreatic and gastrointestinal hormones like glucagon, gastrin, secretin, pancreozymin. Some medications like sulfonylureas inhibitor of insulin release, hypoglycemia, somatostatin. Many drugs like beta adrenergic blockers, diazoxide, phentoxin, phenothiazine, nicotinic acid. Insulin estimation. The main importance The main importance of the main importance of evaluation of a patient with fasting hypoglycemia to predict diabetes mellitus, to assess beta cell activity, to classify the type of diabetes mellitus, to check the insulin resistance, importance of pro-insulin estimations for the diagnosis of beta cell tumor, to find a familial hyper proinsulinemia, to cross-check insulin estimation, the importance of C-peptide estimation for the evaluation of fasting hypoglycemia, for the diagnosis of beta cell tumor, to assess beta cell activity, to monitor the therapy of pancreatomy and pancreas of islet of cell transplant, estimation of insulin by radioimmunization. Radioimmunization is a technique of a choice of measurement of insulin in biological fluid. The test ELISA method is used less frequently. A specimen, the serum or plasma in fasting could be used as a specimen. Urine and CSF can also be used. Heparin should be used for collection of plasma and not EDTA. This is because the EDTA samples use false elevated level in hemolysis should be avoided, since it results in false high level of insulin in a whole blood. Insulin is stable for 4 to 5 hours at room temperature. The serum or plasma can store it for 7 days at 4 degrees centigrade and 2 to 3 days, 2 months at minus 20 degrees centigrade. 0.2 to 0.5 grams of albumin is added to 100 ml 100 microliters of urine samples to avoid denaturation. Principle item 25, label insulin competes with the insulin in patient serum for binding to an insulin specific antibody, which is immobilized on the walls of the polypropylene tube. Then the supernatant is decanted using the gamma counter. The bound iron 25 is estimated. The calibration curves is obtained by plotting percentage of total radioactivity bound against the concentration of calibration. By comparing with the calibration curve, insulin in the sample can be measured. Reagent insulin antibody coated tube which are stable for 1 year at 4 degrees centigrade. Iron 125 labeled buffer insulin. It is a reconstitution 100 ml distilled water, keep it to 10 minutes and mix the inversion. Insulin reference value, the fasting insulin level in a normal BC percent reference 2 to 25 micro international unit per ml. The higher insulin level are seen to be obese non-diabetic persons. Some type 2 diabetic patients decrease insulin level is seen in type 1 diabetic mellitus and in trained athletes. Pro-insulin estimation, it is a difficult procedure since the pro-insulin estimation requires removal of insulin and C-peptide from the fasting plasma sample. C-peptide and insulin are removed by chromatographic technique and then pro-insulin can be estimated. Normal plasma pro-insulin level ranges from 2 to 2.6 per molar per liter. C-peptide estimation, it can be estimated by several kits are commercially available for C-peptide estimation. Normal fasting serum concentration of C-peptide range from 0.78 to 1.89 nanogram per ml. The glucose or glucagon stimulates value ranges from 2.73 to 5.64 nanogram per ml. C-peptide in urine ranges from 48 to 100 microgram per liter. Glucagon, it is a polypeptide secreted by the alpha cells of islet of Langer of pancreas. It is called as a anti-insulin hormone since its action are entirely opposite to that of insulin. The glucagon stimulates the production of glucose in the liver by promoting the glucogenolysis and gluconeogenesis. Estimation of glucose method, comparative RNA method. Principle, the iron 25 labeled glucagon competes the glucagon in the patient serum by binding to a polyclonal glucagon antibodies using the polyethylene glucagon. Secondary antibody found glucagon can be separated from free glucagon bound radioactivity from the specimen sediments compared with that glucagon calibration. For sample fasting blood sample collected in chilled EDT tube since glucagon is very unstable in the blood, a proteolytic inhibitor should be added. Proteolytic inhibitor may be tracelol. The plasma is separated in a refrigerator centrifuge at 4 degrees centigrade. Do not expose it to light. Keep it at minus 20 degrees centigrade. Normal fasting plasma concentration of glucagon ranges from 70 to 180 nanogram per liter. Highest evaluation 500 times value are seen in cell tumor. Female sex hormones. It is very important to know how Hormones can affect the female body, mind, and emotions. The better able we can minimize the negative effect of enhance the positive ones. Infancy, newborn babies may have a slightly enlarged breast sometimes accompanied by a little milk productions due to the female hormones estrogen in mother's body passing through the placenta during the placenta and stimulating breast development in the baby, finally disappearing during the childhood puberty. At puberty, hormone will be begin to make major lasting changes to the girl's body. Breast will get bigger and takes a shape of adult women. Female sex hormones at different stages. The most important hormones made by the ovaries is known as the female sex hormones such as estrogen, progesterone. The ovary also produces some male hormones, testosterone. During the puberty, estrogen stimulates breast development and causes a vagina, uterus, and fill up into to mature. It also plays a role in the growth spurt and later the distribution of fat on girl's body, typically resulting in more being deposited around the hip, buttocks, and thigh. From the puberty onwards, LH hormone, follicle stimulating hormone, estrogen, and progesterone all plays a vital role in regulation of women's menstruation cycle, which results in her period. Each individual hormone follow its own pattern, rising and falling of different points in the cycle, but together they produce a predictable chain of event. One egg becomes ripe and it releases from the ovary and run towards the fallopian tube and into the womb. If that egg is not fertilized, the level of estrogen and progesterone produced by the ovary begins to fall. Without supporting action of these hormones, the lining of the womb, which falls blood and is shed, resulting in the period. Pregnancy. If the egg releases from the ovary is fertilized and pregnancy result, the women's hormone changes dramatically. The usual fall in estrogen and progesterone at the end of the menstrual cycle do not occur. So on period is on. A new hormone HCG produced by the developing placenta stimulates the ovaries to produce a higher level of estrogen and progesterone that are needed to sustain a pregnancy. By the fourth month of pregnancy, the placenta takes over the ovarian as the main producers of estrogen and progesterone. These hormones causes the lining of a womb to thicken, increase the volume of blood circulation, and relax the muscles of womb sufficiently to make the room for a growing baby. After birth, the level of estrogen, progesterone, and other hormones falls sharply, causing the number of physical changes. The womb shrinks back to its normal pregnant size. Pelvic floor muscles tone improves, and the volume of the blood circulation around the body returns to normal. Menopause, the next significant hormone changes for most women occurs around the time of last period. Menopause over 3 to 5 years, leading to the women's last period. The normal functioning of the ovaries begins to deteriorate. This can cause her menstrual cycle to become shortening or longer, or sometimes it becomes quite erratic. Eventually, the ovaries produce so little estrogen, and finally, a period stops. Or ovarian follicle secretes the following hormones. Estrogen is secreted from the follicular tissue. Progesterone is secreted from the corpus luteum and androgen. Estrogen is secreted by the ovaries and placenta. It is synthesized in the granulosa cells of ovary by the harmonization of the androgen synthesis in the thecal cells in the placenta. Testosterone promotes the growth and function of epidermis, a vast difference, prostate, seminal vesicles, the tendency, the maintenance of mobility of fertilizing power of the sperm. It promotes the protein synthesis in the body. Men 2.8 to 8.2 nanogram per ml. Adult women 0.1 to 1 nanogram per ml. The method estimation immunoassay technique like radium ELISA FIA most frequently used method the above hormones in the laboratory.